You know, the good news is in the last 20 years, there have been some very significant advances in treating bladder cancer, both non-muscle invasive, and even advanced disease. But they come at a cost. First of all, many of them are very expensive. But second, there are side effects that go along with some of these treatments. They change aspects of your life. And this next session is really going to be about managing those side effects. And we did talk yesterday a little bit about the role of your physicians, and sometimes the person who is able to spend more time explaining and solving problems are that second tier that are there to help out, and they can prescribe and do all of the same things that a physician can do. It's the advanced practitioner space. They often have more time in their schedules that they're able to spend with you. And very often, you know, many of us have said, well, the doctor's so busy. I know they have to go to the next patient. I don't want to give them my question's going to take a minute. So you wait until you get with the nurse, the advanced practitioners, the PTs, the PAs and the NPs, and then you ask all those questions. And that's what we're going to be talking about. Very often, when we talk about side effects, they refer to them technically as adverse events, which sounds awful. So managing a side effect doesn't sound so bad, but managing an adverse event sounds really serious. And some of these things can be really serious. And I'm really, really delighted that we're going to have a conversation for the next hour and a half. And again, if you have questions, write them down because we will open it up for Q&A. But I'm thrilled to have Brandon Sterling from MD Anderson back here. He's a doctor of nurse practitioner. So he's done all of his work, and he speaks very eloquently, as you heard, about the role of caregivers in all of this as well. So he's definitely going to put that spin on things as well. And he's going to address the urologic perspective. And then we also have Reena Cherry here, and we're just so delighted. She's here from UCSD, and she's a physician's assistant. So it's a slightly different perspective, but she too is the one handling many of the adverse events that go along with being treated for advanced disease or some of the systemic therapies that you're given. So do you have any first initial words that either one of you would like to share with the group before you start your slides? Brandon.
Absolutely. First of all, thank you again for having me again on stage. And I would say that every patient is unique. Every symptom is unique to each individual. So what I'm going to present to you is a broad overview, but what I want you to maintain in the back of your mind is I am who I am, I know my body, and these are my symptoms, okay? And the delightful thing, a lot of people are like, well, can you send me your slides? I would say 80 or maybe even 95% of the information I'm going to present is available on the Beacon website, where they go into great detail about each individual drug, the side effects, and what questions you should ask your providers. And the spin that I'm going to put on it is how to ask those questions, because sometimes those providers, I was talking to Christina yesterday, they can have an inbox full of messages, or the nurses have an inbox full of messages. So sometimes it's not what you communicate, but it's how you communicate. And yes, most of the time the squeaky wheel will get the oil, but again, I want to go over some strategies on how you can communicate those symptoms to your providers to where they'll read it and be like, this is something I probably need to address right now versus, let me just put it in the back of the pile. So as an advocate for patients as well as caregivers, I feel like this information is going to be golden. And if I get some nasty looks from some of the other providers here, that means I've done my job.
Reena, do you have any?
I do. I want to just say, and Brandon and I share a passion for supporting not just patients, but caregivers. And so I want to speak to both groups, so to the patients here and also to caregivers. What you are doing, what you are moving through, it's incredibly difficult. Many of you have been doing this for months, if not years, and the difficulty's been a bit normalized, but what you're doing is really hard. And I think a lot of patients spend a lot of time second-guessing decisions they've made, whether they made the right choice. Caregivers, I think, really struggle always thinking they're not enough. They're not doing enough, they're not cooking enough, they're not supporting enough, they didn't go to enough appointments. And so my general message to all of you is that you're all enough and you're all doing an exceptional job. And part of the way the medical team can best serve you is if we do hear from you early on when you are developing side effects. So as I like to say to patients, there are a few of my patients out there, if we don't know, we can't help. And Brandon's going to speak to how to use the right language to get our attention, but certainly utilize your care team as your coaches. You should not be at home trying to determine if a side effect is significant or if it can be monitored. If you are wondering about it, you need to be making a phone call or sending a message through my chart. So let us take that burden off of you and utilize your team, your medical team, as your coaches and also as your advocates. So.
Yeah. And so, you're not going to be able to change things that you've gone through in the past, but thinking about everything going forward, your eyes are on the front of your head for a reason. You can only see what's in front of you. And now you hopefully will learn some other tips and tricks for making sure that you're traveling the smoothest road possible. So Brandon, I'll let you take it away with your slides.
Okay, thank you. And I'll also add that just from an advanced practice provider perspective, those same frustrations you have with the system, we have those frustrations with the system.
Yes, we do.
And there's been conversations, these hospitals sometimes, they're no better than other corporations. So meanwhile, while, you're trying to communicate with us and you may not be best served because of the volume of patients that we have to see to, again, contend with that corporation part of healthcare right now. So we're all in the same boat. We're just in different seats.
Yeah, that's right.
Okay. So with that said, I'll go ahead and proceed with my presentation. Now, a lot of this information may seem redundant, and the way that I see it as I'm presenting this to you, but you all are the experts at this information because I've never had a cystoscopy before. I've never been diagnosed with bladder cancer before, so you are the experts out in the audience. So I'm going to present this to you, and sorry if it's redundant, but I just want to reaffirm that you are the experts, okay? So as far as non-muscle invasive bladder cancer review, and like I said, I want to speak plainly. I want to speak very similarly to the resources you'll find on the Beacon website, but non-muscle invasive bladder cancer is basically a tumor or a lesion that does not invade into the muscle, okay? And this is usually diagnosed with a cystoscopy. And again, I'm not going to review that because, like I said, you are all the experts, and for you to even be diagnosed with bladder cancer, you've all experienced having a cystoscopy. And during that cystoscopy, if it's in the operating room, they will more than likely perform what we call a turbot, or the transurethral resection of the bladder tumor. And I did get a question one time. It's like, well, why don't they just do these resections in the office? Why do I have to go to the operating room, or why do I have to risk being placed under anesthesia to have this done? And one of the physicians that I work with, Dr. Kamat, he simply stated, well, sure, we could attempt to do it in the office, but if you remember the presentation we just heard about the pelvic floor and all of the muscles and things like that, and he simply stated to me, when you're under anesthesia, you may get a paralytic, so that makes everything more loose, that may make everything more accessible versus you being awake in the office. So when you're awake in the office, all of your muscles are awake as well. So that's why they will take you to the operating room to perform the bladder resections. And when he told me that, I was like, man, that makes complete sense, because I can't imagine someone trying to resect something from a part of my body while I'm awake. That just seems like it's torture. So I wanted to take all the mystery out of that. And if you ever have a thought, well, why are they constantly taking me to the OR or to the operating room? That's why. It's the safest way to do it. And depending on the depth or how extensive that lesion is, they may have to go deeper into the muscle. And again, it's a lot easier once that muscle is anesthetized or paralyzed versus you being awake in the office. So that's why we do that. So once you go through that cystoscopy, or once you have that transurethral resection of the bladder tumor, we've heard it a couple times after during this meeting. That's usually when they will start with the intravesical therapy. They will use some type of chemotherapy while they're in the operating room. So once they have a diagnosis and everything moves forward, that's when they, there it goes. That's when they will decide on the type of intravesical treatment. Now, the BCG immunotherapy is the standard treatment. And again, I want to reemphasize, all of this information is available on the Beacon website, okay? And remember, everybody has different access to different treatments, and this is a discussion that you will have with your provider. And I understand that there are BCG shortages, and that will help determine which route you will go as far as BCG therapy. And, they've done studies, especially through the pandemic, that, BCG, even at half dose, is a safe way to help effectively treat the non-muscle invasive bladder cancer. So if you ever have that fear, or maybe I'm being half treated or I'm not being treated completely, the urologists have done research to show that it is effective. And then we also have the list of the different chemotherapy agents as well. So the thing about the chemotherapy agents, they will give you those typically right after the transurethral resection, and then they will also give it if you are not responsive to BCG. And then now the big thing is, with the different trials, is they're mixing and matching these different types of chemotherapies to give. So I know at MD Anderson, we are currently enrolling patients on the PIVOT trial as well as the Bridge trial, where I'm sorry, the screen keeps flashing up here. Well, where they're mixing either the gemcitabine or the mitomycin, and like I said, and as we heard yesterday, they're trying to mix and match these different therapies to see, what is working for those who are not responsive to BCG treatments. So let's say they've decided to do a combination therapy. Here's a list of those different agents, the gemcitabine, doxycycline, the doxorubicin, and the gene therapy, the new kid on the block. And actually, one of the physicians I work with, Dr. Denny, he helped to actually create and pioneer this drug, is the Siladrin. So that's usually given when you've failed the BCG treatment, and then you're refractory to that, then they get into the different gene therapies.
I'll go tell him about the monitor.
Okay, thank you. Yeah. Now, as far as the treatment schedules go, like I said, they may give you the chemotherapy during, right after the TRBT or the resection of the bladder tumor, and then they wait about 6 weeks, and that's when they will start the BCG treatments. And the maintenance is usually once weekly for 3 weeks, and then as you can see listed there, you have a whole different, you'll have a whole subsequent schedule when it comes to the maintenance. And again, every patient is different. Everybody has may have little tweaks to their therapy, and that may just depend on how well you're tolerating the treatments. So as I said in the beginning of the presentation, this is more so an overview of what to expect. But again, each individual patient, you will have your own schedule depending on your course of treatment and then what exactly is happening. So as far as the symptoms go, and again, this is a broad overview, I would encourage you to go to the Beacon website where they they list each individual drug as well as the symptoms, but this is a broad overview of the different symptoms based on the different type of therapies. So for the immunotherapy, you will have the LUTS, or the lower urinary tract symptoms. So that can be any symptoms from the overactive bladder to the pain or burning while urinating. And then also with BCG, for example, you could have the flu-like symptoms. So that can range from like a cough, body aches. And again, this is an individualized experience for each patient. So again, this is a broad overview of what could happen. And then I will go into what we do from a broad overview to treat each. And then I'm very excited to go into how to communicate these symptoms and when do you feel like they, it's a difference between, okay, maybe I can just send a message versus, no, I need to be seen right now. So again, as you can see, the different treatments have very similar side effects from the lower urinary tract symptoms, blood and urine, pain. But the thing about the blood and urine, remember all of these different bladder installations, they are putting a foreign body into your urethra or that catheter, and then they're putting a substance into your bladder, and that's going to affect the bladder lining. So the blood and urine, again, that's very common, but again, it becomes important where if it's a copious amount of blood and urine. So when you're reporting that, for example, there's a big difference between, I have a couple spots of blood versus, there was a whole cup of blood that came out, or 2 cups of blood that came out, and basically the whole toilet is red. So again, I will get into how to report these. As far as the symptom management, again, it is based on each individual patient's. You will be prescribed, or you can take over-the-counter medication such as the NSAIDs or something as simple as Tylenol or Advil or ibuprofen. And then here, I wanted to really highlight this. If you do have those symptoms and you find them to be more irritative than normal, I always like to encourage the antibiotics after you get the urine culture. And the reason why it's important to get that urine culture is so we can know which species to treat. Because, of course, we can give you the Cipro or we can give you the Bactrim, but what if you have a species, a microbeastie, as I like to call it, or this bug that doesn't respond to any of that? So now we've gone 2 or 3 days of giving you the antibiotic that isn't effective. So it's very important to obtain that culture. And it's not uncommon for them to be like, okay, we'll collect the culture, but we'll go ahead and just prescribe this until something comes back. So again, it's individualized. It is based on the data. And sometimes it's just like, well, how are you feeling about this right now? So there are other medications, the Pyridium or Ditropan, and then also wanted to add bladder installation. So I did a quick poll of my colleagues at MD Anderson and said, so how many times would you go and do a lidocaine installation for any of your patients who are having symptoms with, while on BCG? And all of them were like, excuse me? I was like, lidocaine installations? They were like, oh no, we very rarely do that, and you would have to have some pretty incredible symptoms for us to do the lidocaine installations. And I wanted to highlight that because each of the 5 different primary bladder cancer doctors, each APP had a little bit of a different answer. So I just want to encourage you to go back to your provider and say, hey, I'm having these symptoms, and what do you do at this particular practice? And if you want to bring some ideas to them, I think that's a great idea as well. But I just wanted to preface that with each urologist manages symptoms a little bit differently. It could be based on their training, it can be based on their experiences, and it could also be based on any other issues you may have going on with your body, including your renal function. So you may present to them, oh man, this method of management is the latest and greatest, but it may affect your kidney function or it may affect your liver function. So one of the things that you have to remember, I remember the first time I prescribed a stool softener, and it was like one of the most scariest moments ever, because it's like, man, did I think about all the side effects this could have on this patient? Did I think about everything that could potentially go wrong? So sometimes in your mind, you're like, well, just, write it out. Like, just give it to me. And it's like, wait, it takes a little bit more thought than just to prescribe a pill. So again, this is a great example of, we think about each and every aspect of your care. We're looking at all of the different body systems, especially the nurse practitioners and physician's assistants, because we don't want to do anything to cause you harm. Because as Reena said, you're already here battling these things. We don't want to make it any worse. So now this is where I wanted to really have fun and just give you the emphasis on the caregiver roles and how important communication is. Everybody's an advocate. You, the patient, you are your own advocate. The caregivers, you are your own advocate. And one of the major tips I wanted to pass on to you is establish communication expectations early. You'd be surprised at how many patients, they're like, well, I never talk to my doctor. I'm so frustrated with them. Like, they seem to be always busy. So that's a great question to ask early on. Here I am, I'm going to be receiving my treatment. So who am I going to talk to? And at what level should I escalate it? So at some practices, you may only talk to the nurse. And then it's like, okay, well, I've talked to the nurse and my needs are not being met. So when should I ring the alarm and say, okay, I need to talk to the advanced practice provider or the nurse practitioner or physician assistant? And if that doesn't work, when should I ring the alarm and when should I be reaching out to the physician themselves? Now, I will give you this little insight. Some physicians will give you their cell phone number, their telephone number, but rarely do they expect that you will reach out to them, okay? So it's kind of like a Jedi mind trick. However, if they do give you that information, and if you're not getting what you need from the nurses or nurse practitioner or the other members of the team, go ahead and text them or give them a phone call. They may be shocked. I don't know if they'll answer, but utilize all the tools in your tool belt. And when you're having those conversations up front is, what is the best way to communicate with the team? Is it going to be through a MyChart message? Is it going to be through me calling the office? Establish that hierarchy of communication ahead of time. And then where do I find the resources? So let's say it's a weekend. This is always when it happens. It's Friday night. All of the different clinics are closed. The only thing you have left are, an urgent care center and or, going to an emergency center. So ask your team, this is where I live. This is my physical address. So what should I do on that Friday at 6 p.m.? Again, that's always when it happens. Or that Sunday afternoon. Who should I call to establish help? Or who should I call to get help? Now, I will say, as much as I've talked about the complexities of the healthcare system, since COVID and since the pandemic, they've expanded the methods of communication vastly. And some healthcare systems, you don't even have to go to the hospital, go to the urgent care. They'll set you up with a quick telephone or video visit just to do a quick triage of your symptoms before they give you directions. So ask that question. And I always like to call MD Anderson the land of the milk and honey. And when I say the land of the milk and honey, we have a number or someone you can contact immediately at all times of the day, 24 hours, even if the urology clinic is closed. I'm proud to say we now have an urgent symptom clinic. So if you had some dysuria or if you had a concern, instead of you calling the nurse triage line, you can call the urgent symptom clinic, or the triage nurses will direct you to the urgent symptom clinic versus you just staying on hold or trying to go directly to the emergency center. Because my advice to you is that emergency center truly needs to be used for emergencies only. So one of those symptoms I talked about was the flu-like symptoms. So what would be an urgent care versus an emergency situation? So, a couple body aches, I feel a little flushed and warm. Okay, let's call the triage line or let's call the urgent care people to see what they have to say versus you have rigors, you can't stop shaking. You have a fever of 105, like 102.5 and above. Your caregiver seeing you, you're kind of slurring your words or you're more delirious. That is when you should report to the emergency center. And like I said, it is up to us collectively to triage that and even educate you on how to triage those situations to ensure that you get the care that you need immediately, because yes, the earlier these symptoms are addressed, the better. The earlier you speak to a nurse or someone to triage these symptoms, the better. And it should be the responsibility of the medical team to direct you, okay? That should not be your responsibility. And a lot of these things, like I said, should be conversations up front. Now, I know at that first visit, when you get that diagnosis, you can't think of anything else. You've heard it, it's the C word, and I can't think of anything else. But at those subsequent visits, that will be the time to establish who and when should I call, and then how should I communicate these things. So there is a difference between saying, okay, sure, I'm having these urinary symptoms, I have discomfort. What are we going to do about it? Versus you saying, typically I have the urinary symptoms and there are 2 or 3, but now there are 9 or 10. I can't focus, I cannot concentrate, something is wrong. I now have chills. I do not feel well. I feel like I'm confused. I got lost. You communicating that will make a difference between, let's put this message to the back, or let's, they can wait, versus, no, this needs to be addressed right now, because especially if you have a urinary diversion, I'm sure Reena will go into it, with that urinary diversion, you have a conduit and it's direct access to the kidneys. So I can't tell you how many times we would have a patient who had a UTI, and then the next day or same day they were in ICU due to urosepsis. So early detection is key, and how you communicate these things are key. And even if you feel intimidated or if you feel like you're not being listened to, sometimes that's when the squeaky wheel gets the oil. You call and you escalate. And one sure way to get an answer is you've called, you've escalated, nobody's listening to you, then you call the hospital number. I would like to speak to an administrator on call. I would like to speak to one of the nursing supervisors. And I guarantee you will get an answer, okay? And one of the last things I'm telling you, this is off a recent experience, they do not want to hear from a patient, that their issues are not being addressed. So do not be afraid to escalate it, because in this case, specifically when it comes to urinary tract infections, given all of your advanced ages and given the different complications, as they may be upset, but this could be a matter of life and death, okay? And I've seen it. I have seen it personally. And I don't want to get too emotional about it, but, that's their responsibility. These are your healthcare providers. This is their job to address these symptoms, okay? And in addition to the advocacy, you want to establish your community. And when I say establish your community, look to your left and your right. This is your community. I think yesterday they talked about and discussed the Inspire platform. Sometimes, just reading up on other people's experiences, and you can say, I had that same symptom and nobody listened to me. And yes, I don't want to end up in ICU because my healthcare team didn't acknowledge my symptoms. So the more research you do, the better informed you do, the better quality of those questions are. And like I said, sometimes it's not what you communicate, but it's how you communicate it. And anybody, even a medical assistant, if they see that pain has gone from 2 to 3 to a 9 to 10, I can't focus, I can't concentrate, then that needs to be addressed. And if they can't address it, they need to escalate. And if they need to escalate it, let's take it to the top, because again, this could be life and death. So I'm very passionate about this. I've had recent personal experience, so you do what you got to do, and it is their job to help take care of your symptoms when you do have them. And then also family and friends. I am the nurse resource of all my family. And sometimes I get pictures and text messages, and I'm just like, whoa, I love you. I did not want to get to know you that way. However, they came to me because they feel like they weren't being properly addressed by their own provider teams. And again, sometimes they may not have established health care. So worst comes to worst, remember who butters those hospital breads. It's the insurance companies. So you call that insurance company nurse triage line and you escalate it that way. And let me tell you, you'll definitely get some attention if needed, okay? And a lot of providers or the hospitals may not like this, but sometimes if you have to take it there to save your life, then you have to take it there. It's only going to be a 5 to 10 minute phone call, I assure you. And then one thing I also wanted to highlight is my research, and these are some of the themes that were that came from my research. And it was very interesting because during COVID, when I did the study, there was no face-to-face interaction, so we had to do this all via telephone and FaceTime, and that was one of the biggest themes during COVID. It's like, well, if I'm not present, then I should be able to, how am I going to communicate? So again, telehealth, phone calls, messages, that was key to folks getting their care and communicating with their team. And one thing I really want to highlight was the theme of partnership and feeling connected, that caregiver partnership. The caregivers who I spoke to, they felt like we were on this journey together. And once I saw that my family member was doing well, I felt better. That helped to reduce my level of anxiety. And then also wanted to point out I'm sorry, we still have a blinking screen here. Also wanted to point out the transitional recovery thresholds. And it was fascinating because as each patient learned their new normal when it came to dealing with symptoms or just getting back to, here's, 6 weeks out of treatment, this is how I'm now doing my activity levels, this is how I'm eating. So the better their family members or the patients were feeling, the caregivers also felt that their anxiety was decreasing as well. So it's truly a partnership. And again, you utilize your team members, and I always like to empower the caregivers as well. There's this thing called the eye test. And when I say the eye test, is sometimes I would go and see a patient and I would ask the patient, so how are you doing today? And they'd be like, fine. And in the background, you could see the caregiver, no, they are not fine. They have pain, they're not communicating. And I would look and I would like, okay. And I would take the cue and I was like, so tell me, how's your pain really? And they're like, oh my God, I'm suffering. I've been holding my breath trying to put on a good face. And I'm like, well, you don't have to put on a good face. Tell us the truth so we can help to take care of these symptoms. So you as the caregiver, if you see that your family member is saying, I'm having this burning, this pain, but they look kind of off or they look like not their normal selves, that's when you should ring the alarm as well. Maybe we should call, maybe we should reach out, because in the home, you are the biggest and best tool that we could ever have. Because I don't know what you look like outside of that maybe 20-minute or hour interaction in the clinic. So caregivers, you are on the front lines. You are the person that can, again, it could be a matter of life and death, from you just having a urinary tract infection with irritative symptoms to we are going towards urosepsis. So I can't tell you how important your role is in the home, and you just ringing the alarm like, my husband or partner, they're minimizing their symptoms, but they haven't moved in an hour. I know they are in pain, and I know they're in severe pain, so I'm going to call for you because I love you, and that's what I'm here for. So, I get passionate about it, but with this great savings and we want to decrease costs in healthcare, a lot of the care is actually being transferred in the home. I've recently learned people can get their infusions or their installations at home just because of geographic reasons. And I was like, what? But it's all a part of the cost savings. So again, you as the caregivers, you are on the front lines. You are the greatest resource that we have in the homes. I'm waiting for the screen to... Oh, wow, okay.
Sorry about that. It keeps blinking on the monitor down here, so.
Okay, so again, the direct implications, caregiver involvement is key in the education process. I saw that the gentleman who had that binder or their healthcare Bible yesterday, the caregivers are usually adding pages to that, so that is your role. And then, as I mentioned before, the recovery milestones were a great indicator for the caregivers, like things have changed, things are getting better. And then also, time and experience reduce anxiety. The more that you've gone through this, the more cystoscopies you have, the more that you know what to expect, that help to decrease the amount of anxiety. And then as far as the insider information, again, it is imperative that you learn, who do I need to contact? What is the communication tree? Who do I call for a mild symptom versus a severe symptom versus I feel like I am having a body-wide reaction? Who do I call to report these symptoms to get adequate care? And then ask for the education up front. And then when I say ask for the education up front, I know I had said, oh, we have these really cool barcodes and you can look at this information online. If you need a printed version of the education, request that. Again, it is their job, it's their responsibility to give you that. And then lastly, as I stated before, get those numbers to the nurse triage, the provider triage, have even the insurance provider or nurse triage hotline, and they can direct you as well. So don't be afraid to advocate for yourself, because at the end of the day, as I stated, the earlier we know, the better. And then in certain cases, especially when it comes to urinary tract infections, the earlier that's addressed and treated, the better. And it can make a difference between you just going to the pharmacy and picking up some antibiotics to treat your UTI versus you being in the ICU being treated for urosepsis. So it's very easy for us to sit here and discuss these things, but I really wanted to empower you to communicate with your providers. And I know this may sound a little radical, but by any means necessary, okay? If we have to call, if we have to send messages and escalate, ask for the hospital supervisors or whatever it takes, that phone call or that moment that you spend on the communicating with whomever is a lot cheaper than an ICU admission. So I stand with that, and like I said, some of my provider colleagues may not appreciate that, but it can be a matter of life and death. And with all of that said, I wanted to thank you, and again, reiterate everything that I just discussed will be available on the Beacon website, and then probably here in the next couple months, finally, my dissertation results will be published and readily available to all of you.
Great. So thank you so much, Brandon. I think this has been really, important to just think about, raise your hand if you ever feel like, I don't want to bother them. I know they're so busy. Do you ever feel like that? Yeah, so it's important because you're the one that knows what's going on in your body. You're the one that sees what's happening with your loved one. So if you see something, say something. So now we deal with some of the other more impactful things because they're systemic. They go everywhere.
Yes.
And you're dealing with medicines and side effects and all the other things from those. So Reena.
Yeah, so this is this is actually a very big topic. Okay. Yeah, this is a big topic. I'm going to try to compress it into 25 minutes as much as I can. But certainly if there are a few issues that I can't address here, I'm happy to chat with you off to the side when the session is finished. All right, so what I'm going to do is kind of separate this. We'll talk about side effects of treatment of muscle-invasive bladder cancer, and then we'll talk about side effects of treatment for advanced bladder cancer. And we've seen,
look there
I'm taking my cues over here. We've seen multiple versions of this slide. We're all very familiar with the layers of the bladder at this point. So I'm going to specifically be talking about tumors that invade the muscularis propria. So when we say muscle-invasive bladder cancer, we are specifically talking about tumors that have invaded the muscularis propria. And the reason why that's important is because this muscle layer is quite vascular. So once tumors invade the muscularis propria, there's a much higher risk of hematogenous spread of the disease. So we need to be a little bit more aggressive about treating those tumors. Advanced bladder cancer, or locally advanced or advanced bladder cancer, those are tumors that are locally advanced. So they've either invaded all the way through the muscularis propria, sometimes into the serosal layer, which is that outer layer of the bladder, and or spread to local or distant lymph nodes, and other organs. So those are the treatments that I'm going to be addressing. So muscle-invasive bladder cancer, we have talked a lot about academic organizations. So academic organizations practice evidence-based medicine. And what we mean by that is that we adhere to NCCN guidelines. So the NCCN stands for National Comprehensive Cancer Network. They publish clinical guidelines once every couple of years. This is updated once every couple of years. And essentially, surgical oncologists, medical oncologists, radiation oncologists get together every few years. They research and evaluate all of the data, so all of the results of all the clinical trials. They review all of that and come up with the optimal treatment regimens for the disease. So this is what the landing page, what the landing page looks like when clinicians go into the NCCN guidelines. I also want to be clear that there are patient-centered guidelines that you can look at. So if you pull up NCCN on the internet, there should be a patient option, which is, this is horribly small font and very medically dense. But there's a patient version that is much easier to interpret, and I encourage you to go if you have any questions about what treatments you're on. So when we are talking about treatment for muscle-invasive bladder cancer, we're really aiming at cure. And I use the word cure hesitantly. I don't use that in clinical practice all the time, but I want to be clear that if you have muscle-invasive bladder cancer, the goal is to contain the cancer cells within the bladder and then kill all the cancer cells in the bladder without any of those cells spreading anyplace else. So that is our goal. And essentially, there are 3 options for how to achieve this. So the first option is we can give neoadjuvant cisplatin-based combination chemotherapy, plus or minus immunotherapy, and then you can have surgery. Okay, so that's option 1 is neoadjuvant cisplatin-based chemotherapy and then surgery. Option 2 is you can just move straight to surgery. So you don't have to have any infusion therapy ahead of time. You can just go straight to surgery. Option 3, if patients are not surgical candidates or if a patient just chooses to have bladder preservation, then we can do chemoradiation, which is, we've all talked about this, trimodality treatment of the bladder where you're getting an aggressive TURBT or removal of that bladder tumor, followed by concurrent chemoradiation therapy. So those are the 3 choices. All right, so when we talk about neoadjuvant cisplatin-based combination chemotherapy, first I want to make sure we all understand what neoadjuvant means. When we say neoadjuvant, it means that the clinical team has planned to do surgery, and neoadjuvant is what are we going to do before surgery. And the reason I keep emphasizing cisplatin-based combination chemotherapy is that the data shows that only cisplatin-based chemotherapies improve outcome in the neoadjuvant setting for patients who have muscle-invasive bladder cancer. So if you're not a candidate for cisplatin-based chemo, you're not going to get it. And there is a criteria that we use to determine if patients can get cisplatin. You actually have to have very good kidney function to get it. So we use a creatinine clearance as our guideline. You have to have a creatinine clearance of 60 milliliters per minute or higher in order to qualify to get cisplatin. If you are at the borderline, so if you have 60 is where you are at, sometimes we'll actually split the dose of cisplatin. So you might read somewhere or talk to people who have had treatment, and they talk about, well, my medical oncologist split the dose of cisplatin. We do that to lessen the burden on the nephrons in your kidneys. So we'll take the full dose of cisplatin, split it in half, give you 1/2 of that dose week 1, 1/2 of that dose week 2. And that's entirely designed to protect your kidneys. So there are 2 regimens that we typically use. There's cisplatin plus gemcitabine. That's what you would get if you came to UC San Diego Health and were treated by our team. The other regimen is dose-dense MVAC, which is a combination of methotrexate, vinblastine, adriamycin, and cisplatin. Typically, these agents are given by IV infusion once every 3 weeks. You typically will get 4, sometimes 6 cycles, depending on how we dose it, and then that is followed by a radical cystectomy. So, side effects of chemotherapy. I'm going to hit the highlights. There are There are many, not types of side effects, but patients can experience these side effects at varying degrees, but I'm gonna kind of give you the nuts and bolts today. So fatigue is cumulative. The way we dose chemotherapy, by design, we are not giving you enough time to fully recover from the first cycle of chemotherapy before we hit you with the second cycle of chemotherapy. So your level of fatigue is going to increase as you move through that treatment. Fever and chills. If you develop a temperature of 100.4 degrees Fahrenheit, this is the threshold, that can be the first sign that you have a bacterial infection and you are immunocompromised on this type of chemotherapy. So it is critically important that you notify your medical care team if you have a temperature of 100.4 degrees Fahrenheit. I cannot tell you how many patients sit home and start taking Tylenol hoping that it'll get better. That's actually a very dangerous thing to do. If you develop a temperature, we are likely to tell you to go to the emergency room. We're telling you to do this because we've got to figure out if you have bacteria, and we've got to figure it out quickly. So time is of essence. So we're gonna do urine cultures, we're gonna do blood cultures, and we're gonna start you on IV antibiotics, and it's the IV antibiotics that keep you safe. We can't do any of that if we don't know you have a temperature. So to Brandon's point, it's really important that you reach out to your medical care team. If you're getting chemotherapy with us and you call us and you let us know you have a temperature, we're going to move into action, okay? So that's why temperatures, even at what seems like a low-grade temperature, it's important to report that. Nausea and vomiting, we actually have very good antiemetics that we give. So back in the day, we used to see movies where patients were hovering over the toilet all day, every day because they were getting chemotherapy. That rarely happens now because we have so many improvements in the antiemetics that we're using. So typically, patients will get a long-acting antiemetic at the time of their chemotherapy infusion that lasts about 48 hours. And then you're given take-home antiemetics to use as you need to if you feel nauseous when you get home. A pearl here is that I don't want patients to white-knuckle their way through nausea and vomiting. That is also a dangerous thing to do when you're on chemotherapy. So when you're on chemo, we need you to hydrate with water. You're gonna hear me say that a lot. So hydrate with water, and we need you to be eating. And if you're nauseous, you're not doing either of those. So we really need to control the nausea. We need to jump on it. So there are no prizes for white knuckling your way through this, and it can actually work to your detriment if you do. Small meals, avoiding spicy foods, things like that. Mucositis. Mucositis is a side effect of chemotherapy, so that's an inflammation of the mucus lining of your oral cavity, your pharynx, and your larynx, your throat. Most of the time, we have a magic mouthwash. That's literally what it's called. It's a combination of Maalox, lidocaine, and viscous diphenhydramine. Diphenhydramine is Benadryl, and that really helps to soothe the mucus lining of your alimentary canal. So that's really helpful. Some patients use baking soda mouth rinses. That's also helpful and available to you. Diarrhea is a common side effect. We have patients use over-the-counter Imodium. That's what loperamide is. We will also encourage patients to start using the BRAT diet. So BRAT here stands for bananas, rice, applesauce, and toast. Nice, bland foods for you to eat that help slow down your GI tract and can help mitigate diarrhea. Now, the last three are really critical for cisplatin-based chemotherapy. So cisplatin can actually cause a lot of damage to the delicate nerve endings in your fingers, your toes, and also your ears. So we're screening for this when we're even trying to decide if it's safe to give you this regimen. So as far as neuropathy is concerned, we're gonna be asking you up front if you have any pre-existing neuropathy. So if you have diabetes, if you have any pre-existing neuropathy, that's your baseline, and we need to decide if it's safe to proceed with chemo. If you develop neuropathy as we go, there are some medications that we can use to help slow down this process. One that I really like is gabapentin. The other one is Lyrica, or pregabalin is the other name for that. So we can employ those medications if we need to try to help things. But a lot of times if you're developing some neuropathy, we'll hold chemo for a week or two just to kind of let your nerves recover, and then we can safely resume. Hearing impairment, if you do have hearing impairment moving into chemotherapy, many times we'll have you seen by an audiologist so you can get a full evaluation. If the audiologist gives us a thumbs up that it's okay to start chemo, then we'll do that. And then a lot of times we'll have you follow up with that audiologist throughout chemo just to make sure we're not losing any hearing along the way. And then finally, renal dysfunction. So your cisplatin does a number on the little nephrons in your kidneys, okay? And it is really, really important that we are nice and gentle with our kidneys during chemo. So as I've just explained, you have to hit a certain threshold for kidney function to even get cisplatin, but we also want to protect you once you're on this medication regimen. I cannot tell you how important it is to drink water. This sounds very basic, but there are a lot of people who apparently don't drink a lot of water during the day. So we've got to have you flush this chemo out of your system. Things like soda, coffee in particular, so anything with caffeine in it, even caffeinated teas, caffeine is a diuretic. So diuretics are going to pull water out of your system, and that's exactly the opposite of what we want to have happen when you're on chemo. So I do tell patients, please enjoy your 1 cup of coffee in the morning, 1. But drinking coffee or ladling it down your throat all day is not a good idea. I have nothing good to say about soda. So sugary foods, sugar is also a diuretic. It's going to pull water out of your system. So it's water, water, water. And then if your kidney function is borderline, many times we will get a nephrologist involved just to help us monitor and make any additional recommendations if we need to. All right, so radical cystectomy is obviously part of the treatment regimen, or one of the treatment regimens for muscle-invasive bladder cancer. I'm not going to spend too much time on this because I have a lot to cover. But radical cystectomy, mostly we're doing this robotically now, so I am long enough in the tooth in my career that I started practicing when we were only doing open cystectomies, and now we've moved into robotic cystectomies, so certainly the recovery time is less. But it's still a major surgery. So recovery time on average is anywhere between 3, sometimes 5 to 7 days in the hospital, depending on your medical conditions. The incisions tend to heal quite nicely. Keep in mind, you're still doing a lot of recovery on the inside, okay? We've talked a lot about urinary diversions. I'll show you a photograph or an infographic of what an ileal conduit looks like. I didn't have time to include all of the images for the neobladder and the Indiana pouch, but I know there's one patient in here, where is she, who has an Indiana pouch. If you have any questions about that, you should ask her, because we really don't do that type of reconstruction often. So it's great that it's working for her, but we just don't do that often. Recovery from cystectomy can vary. So if you've had upfront surgery, I would say that your recovery would be on the order of 3 to 4 weeks. So I tell patients, expect to feel about 80% of yourself after about 3 to 4 weeks. If, however, you have had chemotherapy prior to cystectomy, your recovery will be longer, on the order of 6 to 8, sometimes 12 weeks. Why is this? This is because you're not just recovering from cystectomy at that point. You're also still recovering from chemotherapy, because by design, we have not allowed you to fully recover from chemo before we whisk you to the operating room. We don't want you to fully recover because we don't want the cancer cells to fully recover. So it's a very short recovery time between chemo and surgery. So if you have had that combination, your recovery time will be longer. And then we've had a lot of good discussion about physical therapy after surgery. Also, keep in mind you can ask for a nutrition referral. So sometimes, especially if you've had chemotherapy and then you've had surgery, you really need the help of a nutritionist to help guide you and support you so that you can kind of get back to a regular diet. So don't be afraid to ask your medical team for referrals. And then this is just an infographic so you can see what an ileal conduit looks like. You have the ureters dropping down and attaching to a tube of bowel that's created for you. And that bowel actually opens up right into your abdominal wall, and you wear a bag over that, and urine freely drains into the bag. There are a lot of people who are afraid to wear a bag. It's actually much easier than it looks. So there is a learning curve to attaching the bag and learning how to put it on. But you can do literally everything with this bag. You can swim in the ocean, you can play pickleball, you can play golf, you can have sex, you can take your walks for your dogs, you can do anything you want to with this. Neobladders you have to train, as we've heard, you've got to train that neobladder to be continent for you, so that takes a lot of work and effort. And then the Indiana pouch is great for particular patients. So Indiana pouches require you to catheterize for the rest of your life. And there are some patients who are able to do that, and they are able to organize and plan and strategize and get that done. I have had the experience of working with patients who are not able to do that. And so there's a higher risk of infection with Indiana pouches and a higher risk of noncompliance, which can lead to a lot of complications, and that's typically why we don't do it as often. All right, so chemoradiation. So for patients who are not going to have their bladder out and who choose bladder preservation, there's chemoradiation. We typically don't do chemoradiation for patients who have evidence of hydronephrosis before treatment or who have a type of bladder cancer with CIS. CIS is very difficult to see inside the bladder, so it's difficult to know that we've had a handle on it, which makes chemoradiation a little tricky. This is a multidisciplinary approach, so your radiation oncologist is working in concert with the medical oncologist. We literally start chemo and radiation on the same day. So it does take some planning and some strategizing. The chemotherapy given here is radiosensitizing, so it's kind of breaking down the cancer cells ahead of time and then allowing the radiation to work much better. Radiation is typically given 5 days a week for 4 to 5 weeks, and then we go ahead and follow you appropriately thereafter. Side effects of chemoradiation, I'll focus on the lower urinary tract symptoms here. Patients often can get a fidgety bladder during radiation and after radiation. Most of those symptoms are temporary and transient and will resolve after you finish radiation. Certainly, again, hydrating with water helps. Avoiding spicy foods or, foods that are just irritating to you. So citrusy foods can be very irritating to your bladder during radiation. We can employ medications like oxybutynin, which is ditropan, that helps to lessen bladder spasm. There's another medication, Detrol, that we can use. And if your symptoms are significant enough, then we will refer you to the urologist to get their input as well. Some patients will have rectal symptoms during radiation. That's not fun. You can get rectal or fecal urgency. You can get diarrhea. You can get some fecal incontinence. So again, we can have you use Imodium, some over-the-counter remedies for diarrhea, but we also want you to report these symptoms to your radiation oncologist. So most people don't see their radiation oncologist very often, so they tend to report symptoms to the medical oncology team or the urology team. But particularly if you are moving through radiation, it is very important that you loop in your radiation oncologist too so that they can help us problem solve. All right, advanced bladder cancer. So this is the landing page for the NCCN guidelines for advanced bladder cancer. It's a very busy slide. I'm going to focus our attention where these 2 red boxes are. We have had, over the past 2 years, a pretty groundbreaking new treatment regimen for advanced bladder cancer. It's enfortumab vedotin and pembrolizumab. I love this drug combination. We use this all the time for patients. It can be a little bit tricky, but we're just so happy to have it. The results of this treatment medication have been pretty amazing. So 2 years ago, it would not have been on this slide, but here we are. We're happy to be in this space. Enfortumab vedotin is an antibody drug conjugate. And what that means is it targets and binds to Nectin-4 receptors that are on the tumor cell surface. I like to call this the Trojan horse of chemotherapy. I'll explain that in a minute. We typically dose enfortumab either 2 weeks on, 1 week off, or 3 weeks on, 1 week off. It really depends on how your medical oncologist wants to dose it. And I will tell patients up front that we are going to dose reduce this. So this is because this is a targeted chemotherapy, it doesn't impact your bone marrow as much. And so because of that, we can actually give enfortumab vedotin for an extended period of time. So the name of the game here is to find the dose that works best for you and keep you on it as long as humanly possible. All right, so here is a graphic of how enfortumab works. So the drug is actually contained in a capsule, and that capsule attaches to the Nectin-4 receptors on the cancer cell, and the cancer cell envelops this capsule and invites it in. And once the capsule's inside the cancer cell, the capsule opens up, the enfortumab spills out, the enfortumab kills the cancer cell and sometimes some of the surrounding cells. It's awesome. But it does come with some very specific side effects. So this drug absolutely, positively will dry out your skin, 100% of the time. It'll also dry out your eyes. It also causes skin rash, so it just is not nice to our skin, and I'll talk to you about how to mitigate that. Neuropathy is also a very big side effect here. So numbness and tingling, again, of your fingers and toes. Neuropathy is actually, I think, anecdotally, the biggest or the side effect that dictates when we dose reduce and how long we're able to keep patients on this regimen. So this is a big one. Food also tastes terrible on this drug. If food were a color on enfortumab vedotin, it would be gray. And sometimes it's a little worse for patients, sometimes it's better, but generally speaking, it's gonna change the taste of food. So what do we do for dry skin? I have patients lotion, and this is crushing for most men, because I found out most men don't lotion, ever, apparently. So if we're even talking about enfortumab, I start patients lotioning before they even get the first infusion, because the name of the game is to get your skin to be moisturized and stay moisturized, and it significantly reduces the amount of itchiness and the amount of rash that you have. So I have patients lotion in the morning and at night, and it's imperative that you lotion right after you bathe, because you'll lock in the moisture from your bath or your shower. So that's one of the things we do. If you're having itchiness or you develop a rash, we'll start you on some oral antihistamines. So I like to use Claritin in the morning. There's a prescription antihistamine that I like to use, which is Singulair. And those just kind of dampen the histamine release that happens when your skin is irritated, and it really helps to prevent all the itchiness. This medication can cause dry eyes too. And when enfortumab vedotin first came on the scene, we did not know this, and patients got into trouble with their vision. So I don't mess around with eyes. So if your eyes get dry, and this can present in one of two ways. Your eyes can either feel dry, so when my eyes get dry, they just feel dry. But for some patients, they'll develop actually runny eyes. So their eyes just start to run. And that is a sign that your eyes are dry. So if your eyes get dry enough, your brain tells your eyes, make more tears. So you want to report these symptoms to your medical oncologist. We'll start you on over-the-counter drops. Please, God, do not use Visine. But like Refresh drops, those are really good drops to use. And if your symptoms are severe enough and or if you're developing visual acuity changes, that is a stat ophthalmology referral. So if you're on this drug and you think in any way your visual acuity has changed, that is a stat message to the team, and you need to use the words, I am having changes in my visual acuity. You will get a call back. Neuropathy, we've talked about, is a big one. Neuropathy is self-limiting, so many times on this drug regimen, what we'll do is we'll hold the drug, let your neuropathy resolve, and what we're looking for is functional deficits. So if your fingers or toes are just a little bit numb, but you're walking okay, and you're able to manage money, if you still use cash, or papers or whatever it is, buttoning up your shirt, we're fine. But we want to catch the neuropathy before you develop functional deficits. And the reason why we want to catch you before you develop the functional deficits is that most of the time, neuropathy is self-limiting, meaning most of the time, your symptoms will resolve and you'll go back to baseline. Occasionally, you don't. So what we don't want to do is get you to a place where you're having functional deficits. You're tripping, you're falling, you can't grab your phone, and then at that point say, okay, we're gonna hold treatment. If you stay in that place, that's a huge quality of life detractor, and we don't want you to be in that space. So that's why we're constantly talking to you about levels of neuropathy. Dr. Stewart and I work with Dr. Stewart, who spoke yesterday. we will actually have patients walk down the hall. I call it a catwalk. I'm like, all right, we're gonna walk down the hall. I'm gonna watch you walk, because also patients don't necessarily report symptoms the way I see. So I want to see you walk. So those are things we're doing to try to catch neuropathy early. Diarrhea, we've learned to dose this medication really pretty well, so I don't see a whole lot of diarrhea from enfortumab vedotin anymore, but there have been some pretty severe cases. So again, if you develop diarrhea on this drug, the name of the game is to tell us early so we can intervene. Again, the brat diet, over-the-counter Imodium, all those work. We've talked about how food tastes terrible. A blurb here, I look in everybody's mouth when I see them in clinic, and I'm kind of horrified at what I see. We need to do better with our oral hygiene. Everybody needs to do better. Also, okay, great, great. I'm shocked. So we need to floss, we need to brush our teeth, we need to brush our tongue. I can't believe, you gotta brush your tongue. So also, what I'm looking for is for signs of thrush. So if you have had, particularly if you've had chemotherapy in the past, a thrush is kind of sneaky. So thrush is a fungal overgrowth on your tongue. It's very sneaky, but if you develop thrush, food won't taste good, and we can do something really easy like a nystatin oral swish and spit to kind of get that fungal overgrowth off your tongue, and typically that is quite helpful. All right, so moving on to the other part of this combination treatment, which is pembrolizumab. Pembrolizumab is immunotherapy. I will briefly describe immunotherapy to you. Cancer cells are tricky. So cancer cells learn that if they attach themselves to our T cells in specific places called checkpoints, the cancer cell can actually disable that T cell. So what immunotherapy does is immunotherapy gets infused, and immunotherapy actually blocks the cancer cell from attaching to the T cell in that place. That's why we call immunotherapies checkpoint inhibitors, okay? Immunotherapy can impact almost every organ system. So what can happen is that once your immune system is not disabled, it can get overly excited, and it can start attacking healthy cells. And it can do that in almost any organ system. I'm going to hit the highlights for you because we don't have time to go through all of them. But pneumonitis is common. If you develop pneumonitis, you would develop cough, chest pain, some difficulty breathing. It can impact the liver, so you can develop hepatitis. Most incidences of hepatitis are mild, so we're looking for elevations in your liver function studies on your labs. You will likely feel fine, but we're looking for evidence of this on your labs. Colitis is also very common. Colitis, or inflammation of the bowel. What you would experience is diarrhea, and it's going to be a watery diarrhea with immunotherapy. Endocrinopathies are also quite common, so patients can get a transient hyperthyroidism followed by, unfortunately, a permanent hypothyroidism on immunotherapy. We also see things like adrenal insufficiency, which again we would pick up with symptoms, but also we're looking at your cortisol levels every time you're getting an infusion. Dermatitis, we kind of talked about that already, so this can cause rash that we can use topical steroids for, arthritis, and then very rarely encephalitis and myocarditis. So if you are on immunotherapy and you develop headache, visual changes, balance issues, or if your significant other or your caregiver says, you know, you just don't sound right, like something's off, that is an immediate phone call to your medical care team, okay? And then the treatment for almost all side effects that are immunotherapy related, some form of steroid. So the answer to any multiple choice question about how to treat side effects from immunotherapy is steroids. So if you have a rash, we're using topical steroids. We also use quite frequently oral steroids. We're giving a burst of oral steroids 5 days and then we stop, or if you have significant side effects, sometimes we start with a very high dose of oral steroids and we do a very, very, very slow taper just to make sure that we are really calming down that immuno response. Immunotherapy, we either give it or we don't. So we don't dose-reduce immunotherapy ever. And we're very focused on whether or not we need to hold immunotherapy treatment. So if you're having a side effect and we suspect that it's immunotherapy related, we're likely to just hold the immunotherapy. We'll sometimes go ahead and give you the EV. We'll just hold the immunotherapy. If your side effect is significant, if you have landed in the hospital with a grade 4 hepatitis, or if you have encephalitis or myocarditis, and you're getting IV steroids in the hospital, we are very likely going to have a conversation when you get out of the hospital, and it's unlikely we're going to restart you on that immunotherapy. It's just too dangerous. So hospital admission with IV steroids is one of the reasons why we would go ahead and discontinue permanently. And then in some refractory cases, we did have one patient not too long ago who developed diarrhea. We think it was probably more so from the enfortumab, but we can't be sure. And that was a refractory case. So we tried high-dose steroids, nothing seemed to work. We did do infliximab. Infliximab is an immunosuppressant that we use. So sometimes in refractory cases, we do have to resort to that. And that's about it. So again, this is a lot of information. I would just like to say one more time that you all are doing an amazing job. Whether you think you are or not, you're doing an amazing job. Give yourself some grace. Certainly listen to your body, as we've talked about earlier. You are like the masters, the CEOs of your own body. So if you are suspecting that something is not right, trust yourself and keep contacting us until somebody listens to you. Please also, if you're developing a side effect, it is far easier to help you when the side effects are new. It's really difficult once things kind of get out of hand. So please report to us earlier. And that's it. You guys got this. That's all I got. Thank you very much.
So all of these treatments now can help you live longer, and many of them can help you live better, but it is on you to get help when there are some of these unwanted consequences from the treatment. So let's open it up to some questions. We've got about 15 minutes for questions. The first one is over here, and then we will be breaking for lunch, which will be outside, and bring it back in here for our last session, which will be the latter part of lunch. So let's start over here.
So my first question, since obviously we're talking about side effects, this is something, as you presented, is a known possibility of things that are happening. I'm kind of curious why, because I just learned some stuff from my sister having cancer that I never heard before. Why is, if it's a known possible side effect, is there no one talking about the possibility of how to possibly avoid the side effect, if that's a known cause of that treatment, or how to potentially reduce the side effect? And then a second kind of partial question is about timing. Mm-hmm. You know, we live our lives, we don't want to have every twinge think, oh my God, the cancer's come back, but when can a side effect happen? If you've been, like myself, over 2 years out of treatment and something happens, is that potentially a side effect because I had chemo and immunotherapy, or is it just a coincidence?
That's a great question. So, first part of the question. There are many things we do to try to prevent side effects ahead of time. So if you look at our, like a treatment plan for chemotherapy, we have woven in many, many pre-treatments into that infusion for you to try to prevent infusion reactions. So patients are getting Benadryl, they're getting long-acting antiemetics. All that is getting infused into you at the time of chemo. And then we're giving you medications to take at home. So things like nausea, vomiting, acid reflux, infusion reactions, all those things we do plan for, and those are embedded in your chemotherapy treatment plans. At least they are at UC San Diego Health, and they were at MD Anderson. I've worked in both places. Your second question about when to know what's a twinge and what's a side effect. As far as immunotherapy is concerned, there's a saying in medicine that once an immunotherapy patient, always an immunotherapy patient. So if you have had one infusion of immunotherapy, you can have a side effect really, it can happen at any point in time. It can happen acutely. It can happen a year later or 2 years later. I know that's probably not what you wanted to hear, but it can. So knowing what these guidelines are, kind of having an idea of what the immunotherapy side effects are, and then again, you're sort of the best judge. So I don't mind if patients say, my skin's a little bit itchy here, I'm just gonna see how that goes. If within the next day or two you're still itchy or you're more itchy, I would wanna hear about that. So you have to kind of use your body and the way you know your body's response as a baseline, and what we're looking for is anything over and above that baseline. So that's how I would tell you to approach it. It's a really good question because you don't have time to, nor do we have time to field questions every 5 minutes, but if you just sort of kind of get quiet with yourself, and a lot of times patients will have a hunch. So patients will have that, this just doesn't seem right. That's really when I want to hear about it. Because sometimes I can give the feedback pretty quickly, like, yep, nope, that's normal, you're fine. But I want you to pay attention to the voice in your head that says, this is not right. That's what I don't want you to ignore. And so that would be my advice.
Okay. And then also get questions of why can't you just give me antibiotics to take whenever I have symptoms? Well, the thing about antibiotics and antibiotic stewardship, if you take antibiotics that you don't need, then your body will learn to resist, or those microbeasties will learn to resist those antibiotics. So what we would normally give you, but if we're always giving it to you, it won't respond, the microbeasties won't respond to those antibiotics. So one thing we have is antibiotic stewardship, which is why I emphasize you want to make sure you're getting that urine culture before you get the antibiotics, if possible, because the last thing you want to do is get a microbeastie or an organism that's resistant to antibiotics. Because if you get a urinary tract infection that's resistant to the normal over-the-counter antibiotics, that means they will give you all the antibiotics in the world, but it's not going to work. So that means you have to go to the ICU or go to the hospital to receive stronger, more powerful intravenous antibiotics. So there's a method to all this madness, okay? And nobody's necessarily trying to stop you from getting treatment, but we want to make sure that we are using our better antibiotic stewardship. It's almost like people who get a sniffle or cough, they're like, well, I need antibiotics right now. Well, if it's a viral cause, the antibiotics is not necessarily going to do anything for you. It may help with you mentally. You may think, oh, I'm getting better, but it's really not fighting anything if it's a viral infection.
I think I had the next question, or it's actually elaborating, Brandon, on what you said, sepsis. And I think, when you're coming out of a radical cystectomy, you're feeling really crappy. I didn't know what the symptoms were. And they can come on really fast. So just re-emphasizing what you had, and I think, in retrospect, it's, those couple night sweats a few nights later, and then I felt fine in the day. And then the next day, had lunch with my son, took a nap, and could barely get up to go to my surgeon appointment. She took one look at me and wheeled me to the ER. And fortunately, didn't affect my organs, but I was in the hospital 8 days and on very intensive medicine for 20 days at home. And you don't want to be paranoid about every possible complication, but things like that, it's just sharing that it can sneak up on you within an hour or two, especially after a major surgery like that. It's pretty scary. And now every subsequent surgery, it's like, okay, now I know what that is. So thanks for flagging it. It's super important. And both of you for your comments.
The psychological and emotional impact of cancer is like a 100-mile-an-hour brick to your forehead, not only for the caregivers, but also for the people that have cancer. Medicare, for people who are eligible, has a nationwide network of licensed clinical social workers, and there's no cost for that, which is a recent program. And not only with the initial care, but also for the follow-up care. So if you go to totallife.com, they'll hook you up with a social worker and therapist at no charge.
Oh, that's great. That's fantastic.
Yeah,
This is more of a statement. I work with Stephanie. I came here to support Stephanie, and I stayed for the party. But I'm not a pelvic therapist. I'm a lymphedema specialist in rehab, and that's one of the signs and symptoms that we typically don't see, and we didn't see in the presentation today. And so that's lymphatic dysfunction and issues with the lymphedema system, issues with swelling of the limbs, often isn't generally addressed until it's a little bit too late. And since what we're hearing a lot here is everything that's addressed really early is really easy to manage. And there's some really excellent pathways for other cancers to the lymphatic department, but there seems to be not as much of a good pathway for lymphatic, for pelvic cancers. So that would be, I would just urge people that your legs don't necessarily have to be huge. Those huge pictures that you see when you look up lymphedema online, your legs can feel heavy, they can feel tight, they can feel uncomfortable, and that's early signs of lymphatic dysfunction. And if we can get you early, then we can manage that lymphedema.
Thank you. That was a really good point. We've done sessions that brought in lymphedema specialists in the past, and that's such an important aspect because they often impact so many people when you've had surgery. So thank you for sharing that. So always ask about treatment.
yeah, hi. I'm not in a situation where I need to worry about a lot of these things, but just looking at it is worrisome. I'm wondering, do you do any assessment of quality of life, the pros and cons of, hey, just live out another 5 years, screw this stuff, right? Or take your chances and, spend the rest of the time in the hospital and back until you croak. Do you do any kind of assessment of quality of life?
So that is a good question. What I would say is when we are evaluating a patient, our job is to tell you what treatment options are available to you. So no one is obligated to get treatment for their muscle-invasive bladder cancer. No one's obligated to get treated for their advanced bladder cancer, and there are going to be inherent side effects. So there are some patients who present to us, they want a very aggressive treatment, and we assess it's called what you're talking about is overall performance status. So how do they look to us? Are they in good shape when we see them? Do they have a lot of medical issues? And our job is to assess those medical issues and let you know what your quality of life might look like on the treatment. But we can't make that decision for you. But there are certainly patients for whom we do not recommend surgery, or we do not recommend chemoradiation therapy for a variety of reasons. So we do try to give some boundaries and provide some scaffolding for you to use as you're making your decision. But there are some patients who just decide they don't want to incur the side effects of whatever treatment options we're offering, and that is their choice. But we do try to give you as much information as possible about whatever side effects you may have so that you can make a fully informed decision.
And I would like to add to that. Sometimes you're not thinking about quality of life and thinking about a survey. So the better approach would be, it's just you telling your providers, this is what I love to do. I love to go swimming in the lakes during the summer. I love to go skiing in the winter, or I love to, go hiking. So that would be another way for you to approach it as a patient or caregiver, because that will hopefully tune in that provider to, oh, okay, I know we have this list of side effects. I know we talk about quality of life, but what does quality of life mean to you? And what does quality of life mean to your family? So I think that's also an approach as well, because we can give you the prescription. I mean, in every medication, there's like a little insert of the different side effects, but more importantly, You know, what do you value as an individual? What activities do you want to continue to do as you pursue treatment?
Yeah, and that's what I talked about yesterday with it's on patients to share in that shared decision-making, because you're the one that wants to live longer and you want to be able to continue that thing that is really important to you. And asking, how is that going to impact my ability to play the violin? You know, knowing that neuropathy is an issue, maybe that's not the best treatment option for you. So those are all things that you all know better than even the doctors do. So one last question before we break
Thanks.
for lunch.
I have two last questions, but they're quick. There's different types of chemo and different types of immunotherapy that you both discussed. And the first question is, I'm wondering if someone has adverse reactions to one particular type of chemotherapy or one particular type of immunotherapy, does that mean that they're necessarily going to have similar reactions to the other types of treatments that are available, or could one be a real problem, but the other one may work fine? And the second question is sort of related. In the broader cancer community, a lot of these agents, chemo and immunotherapy, are used for different types of bladder cancer. So a number of us have relatives that have totally different type of cancer, right? And there's conversation, oh, well, I'm on this chemo or I'm on this. To the extent you talked about side effects that are not specifically bladder related, but that are systemic, would the treatments you've talked about and the side effects for these other types of cancer be similar depending on, you know, each person, or are these systemic side effects unique to bladder cancer patients? So those are my two questions. Thank you.
So for immunotherapy, the systemic side effects that I talked about, those are side effects that anyone can experience, but everybody is different. And your immune system is not like anybody else's in this room. So it's really difficult for us to say, you know, I have no idea. Like the person sitting next to you could get the exact same immunotherapy and do just fine, and you could be riddled with dermatitis and endocrinopathies and all of this. So immunotherapy is, I have found, it's a little bit more specialized and to patients. So we manage side effects quite differently. What you're talking about is kind of waiting room talk, which is hard for us as clinicians because sometimes you will pull and extrapolate information from the person sitting next to you when you don't really have the full idea of what they've had in the past, what their reactions were, how those resolve. So there's so much that goes into the decisions we make about the treatments we offer. But certainly with immunotherapy in particular, so let's say you got immunotherapy and it was Keytruda or pembrolizumab, and you had a horrible, let's say you had severe hepatitis. So we had a patient actually not too long ago who had one dose of immunotherapy and her liver enzymes were in the high hundreds, which is quite scary. Would I take her and say, well, this is your reaction on pembrolizumab, let's try nivolumab? I would not do that. Because in general, immunotherapy, all the immunotherapies are likely to cause that same type of hepatitis in her, okay? So I don't think we would leisurely make a decision to just switch immunotherapy. For her, if the side effect is bad enough, she's done with immunotherapy. There are some occasions where we can give, so we had one patient who had really bad colitis years ago when he had immunotherapy, and we talked to GI people, we talked to infectious disease people, and we did actually pre-treat him with some immunosuppressive agents, and then tried him on immunotherapy, and he did well for a while, and then we had to take him off. So occasionally we'll make a decision to retry. To your point about chemotherapy, certainly, like if you came to us and you had advanced bladder cancer and you had not tried any other treatments, we would put you on EV-Pembro. If for some reason you don't tolerate EV-Pembro, first of all, the name of the game, when we put a patient on a any sort of a chemotherapy regimen, whether it's oral or infusion, we are trying to get as much life out of that treatment as humanly possible. So what we don't want to do is just arbitrarily leapfrog our way through all the treatment regimens. We really try to like suck the life out of that treatment regimen. So if for whatever reason you were not doing well on EV Pembro, we would try to manage your side effects as long as possible. And then sometimes we do get to a pivot point and we say, okay, we're going to try cisplatin, gemcitabine, or carbogem. So those are the times when we have to make those treatment decisions. But we try not to do it arbitrarily or too early.
And I know that Brandon and Reena will be here through lunch, and I want to thank you both so much. This is a really powerful session.
Thank you.